Hi everyone, I want to talk about nosocomial pneumonia. Don't worry about the big name, that simply means hospital-acquired pneumonia. I have talked about community-acquired pneumonia before. Check out my presentation on this channel on that. Let's go. Hospital-acquired pneumonia or nosocomial pneumonia is the type that occurs after being on admission in the hospital for at least 48 hours. It could be more, but at least 48 hours. It can be ventilator-associated pneumonia, and that is, it develops after being intubated for more than 48 hours. The problem here is the occurrence of a multi-drug resistant pathogens, and the culprits here are Pseudomonas aeruginosa, Acinetobacter, methicillin-resistant Staphylococcus aureus. We need to rule out multi-drug resistance, any antibiotic intravenously in the last 3 days. That's part of the issue we want to take. Septic shock on admission, any acute respiratory distress before you were being ventilated. Have you been admitted for more than a week? Do you have methicillin-resistant Staphylococcus aureus or methicillin-sensitive Staphylococcus aureus? Many or majority of the patient might not be able to furnish the doctor with this history, but the treatment records might show that. And particularly, most of them are even in the hospital. So why don't the ward round just go over the record and be able to pick all this? How do we make diagnosis here? When it's the case of hospital-acquired pneumonia or ventilator-associated pneumonia, we are going to culture pulmonary secretions, sputum for microscopic culture and sensitivity test. We will check the endotracheal tube, and whatever aspirate there, we're going to keep for investigation as well. Bronchoalveolar lavage could be done with aspirate. False positives and false negatives are possible, and from all the devices that the patient is placed on, we're going to take samples. We'll run complete blood count, arterial blood gases, know what we're dealing with, respiratory or metabolic acidosis here. You do chest x-ray, and if that chest x-ray is not convincing and you have the facility to do that, CT scan, and of course, bronchoscopy. When you are sure this is pneumonia and it's nosocomial, then the next thing is to continue the current admission, or if the patient has just been discharged and been brought back to the hospital, then admit. Check the airway for any secretion, any foreign body, remove as is appropriate or suction. Check the breathing, the chest region, any deformity, any flaring of alar nasal or other accessory muscles of respiration being used, for cause, for donors, tympani or anything, auscultate, count the respiratory rate, check the circulatory system, the blood pressure, the pulse rate, the fluid status, dehydration, cyanosis, even under breathing, and put your IV fluid up, tazocine intravenously, levofloxacin or telanvacin, vancomycin, and you change to per oral when stable. When the result of arterial blood gas is back, then correct as it may be required. We can review the laboratory and radiological investigation results to further enhance our management strategy, and it depends on the protocol where you work. The oxygen saturation, and you administer oxygen as it may be required. The risk factors here will be old age, like in my grandfather or grandmother, opioid usage. That doesn't mean we're not going to use it if the patient is on admission and we need that to relieve the pain. Central venous catheterization, glucocorticoids use, muscle relaxant use, mechanical ventilation, and chest surgery. Also, decreased level of consciousness, chronic obstructive pulmonary disease, paralysis, previous hospitalization, malnutrition that will lead to decreased immunity, and past broad-spectrum antibiotics usage. Prevention. Avoid intubation if you can avoid it. But that doesn't mean don't intubate. Thousands of people are intubated worldwide on a daily basis. Lower rate of transportation while on ventilator. Minimize use of sedatives. That is not to say don't use it. Decrease pool of secretions above the endotracheal tube by suctioning. Raise the head of the bed. Implementation of weaning protocols, depending on your center. Change ventilator circuit only if soiled or if malfunctioning. In other words, reduce the rate at which you change it. Encourage early mobility if it is possible. Please let the patient start walking around as soon as he or she could. Assess readiness to extubate every day. And once you are able to make that determination, please do. Saline instillation before tracheal suction. Mechanical toothbrushing, oral or gastrointestinal decontamination. In conclusion, I'm not done yet. Kindly check my presentation on aspiration pneumonitis and aspiration pneumonia. And because they are closely related to this, you are going to get the clinical features, treatment, and so on from those two presentations. The pattern of treatment and clinical features will be similar. So check the two presentations, one on aspiration pneumonitis, the other one on aspiration pneumonia. Then I will now go over the clinical presentation and treatment and the rest here. Watch out for them. Check them already, they have been published. Thank you for listening to my presentation. Kindly subscribe so that you can get these presentations immediately they are published. Thank you.